together at the back, come on up and fill in some of these seats closer to the stage. All right. Welcome, everyone. Those of you who are here in person and those people who are joining us via live stream, we're happy to have you at the Paul Torrens Health Forum. I'm Laura Erskine. I am the director of the Center for Healthcare Management, faculty in the Department of Health Policy and Management, and the director of our newest master's program, the Master's in Healthcare Administration. So on behalf of the center and the Fielding School of Public Health, thank you for joining us. I also want to thank the many donors that make tonight and the health forums in general possible. As many of you know, the health forum is named for Paul Torrens. Paul Torrens passed away in December, but for more than 40 years, he guided and mentored and advised students and alumni, helping them shape very distinguished, very fruitful, very productive careers in public health. The Health Policy and Management Alumni Association will be giving a tribute to Paul at this year's Leaders of Today, Leaders of Tomorrow dinner, which happens this year on May 4th. By tradition, we also take the opportunity once a year to highlight the legacy of a beloved Fielding School professor, the late Ruth Romer. In a word, Ruth was an icon in public health. She intentionally pursued a career path that prioritized socially relevant public health work. She has a law degree. She had a law degree from Cornell University, where she met her future husband, Milton, and found a unique niche at the intersection of law and public health. After joining the faculty at the UCLA School of Public Health in 1962 with Milton, she became an activist, taking up such controversial health issues as abortion law reform and the addition of fluoride to public drinking water. She also used her legal skills to fight against the discrimination of people with HIV/AIDS, but perhaps is best known for creating the framework for the World Health Organization to launch the first International Convention on Tobacco Control in 1993. Professor Romer was an active and beloved faculty member at our school for more than 40 years, and even at age 86, she was teaching every quarter. So we are honored tonight to have Ruth and Milton's daughter, Beth, with us. And I want to invite Beth to say a few words. So Beth, welcome to the Health Forum. Beth followed in her parents' footsteps, earning an MPH from UC Berkeley. She retired in 2019 after a 40-year career at Kaiser Permanente, having had a wide range of roles. My apologies, Beth. Having a wide range of roles, including hospital and medical group administration, strategic planning, quality improvement, medical education, and equity, inclusion, and diversity. Most recently, she was a key leader of the team that created the new Kaiser Permanente Bernard J. Tyson School of Medicine in Pasadena, where she became assistant dean. So welcome, Beth. It is a pleasure to have you here tonight to share a little bit more about your mother's legacy.
Laura, thank you so much. Can you hear me and see me?
We can hear and see you.
Oh, great. Terrific. Good evening, everyone. I'm sorry I can't be with you in person. It is such an honor to participate in this forum. My heartfelt thanks to the Fielding School, to the late Paul Torrens, and especially to Laura for honoring my mother with this event. In these challenging times, I have long thoughts about what Ruthie would have to say about the current social justice issues that are were near and dear to her heart. I think about the women's reproductive rights and the Dobbs decision, and now the Texas ruling, the rule of law and the indictment of Donald Trump, the mass shootings, and the opposition to reasonable gun legislation. Long thoughts. So I'm happy to have a chance to honor her this evening. I was going to tell you, I've been planning to tell you about Ruth's work in support of caregivers, her work on scope of practice legislation. But I think you might be more interested, or at least you might enjoy, a more personal story. Ruth was a lawyer, a teacher, an advisor, a staunch political advocate, and much more. But at home, she was known for her other profession, what we in the family lovingly called Arrangements Incorporated. As president of that one-woman endeavor, she helped anyone who crossed her path. People came to her with all sorts of problems. Maybe you did? I certainly did. Do you need a job, a reference? Do you need a wife, a husband, a place to live, a caregiver for a parent or a child? Perhaps she would make a phone call on a Sunday morning to a health minister in a faraway country because you were interested in international work, or she would do that by typing a letter at her manual typewriter. Her network was just amazing. She might invite you to dinner at her home, and sitting around the table, one of the guests might be a potential romantic partner or faculty member in your field of interest, or someone who had a job opening in their department for a research associate. Perhaps you were the beneficiary of Arrangements Incorporated. I know that I was. In this way, Ruth was a unique caregiver to many, many people. Today, I know Ruth would feel deep admiration and compassion for the healthcare professionals who sacrificed so much to provide care to patients with COVID during the height of the pandemic, and appreciation of the dedicated public health practitioners who were faced with increased distrust and were attacked from all sides. I'm privileged tonight to convey my family's appreciation for the devoted caregivers and public health practitioners like you that we need now more than ever. Thank you again for honoring the memory of my remarkable mother.
Thank you so much, Beth. It was great to see you tonight. And now I'd like to continue honoring Ruth Romer's legacy through the next part of this evening's program, the panel presentation and discussions. So a few housekeeping notes before we begin. We encourage questions from the audience, and there will be some time set aside at the end for that to happen. You can also learn more about tonight's session by scanning the QR code, which will appear on each of the panelists' slides. So, for years, we've been forewarned about healthcare worker shortages, but now that's compounded by people working for more than 3 years beyond capacity. And I'm so pleased that Barbara's here to start us off to talk about this really important conversation around burnout and engagement in our healthcare caregiver community. Barbara?
Okay, great. All right. Thank you, Laura, and UCLA School of Public Health. It's such an honor to be here and to see all of you here to talk about a subject that's so important. And this is caring for the caregiver and the healthcare worker. I first would just like to start out about defining what the healthcare worker is. So this is nurses, physicians, respiratory therapists, social workers in the health field, pharmacists, health aides, nursing assistants, medical assistants, anyone who serves in a critical support role for delivering healthcare. And currently in the U.S., there's 22 million U.S. health workers. And for health workers, there is kind of a little bit more challenging work condition and environment that puts them at risk for mental health problems, everything from stress, anxiety, to depression, burnout, substance use, suicidal ideations, behavior, and more. And it's important to note as well that before the pandemic, this was a concern and an issue. And then the pandemic hit, and we know from the research and the data, or maybe your own subjective experience, that it really heightened through the pandemic. So self-reported challenging work conditions from all healthcare workers talks about the long hours and the intensity of the workload. Intense as far as emotional burden, physical labor, physical burden. And with the long work hours, there's often rotating or irregular shifts. So many nurses in this building right now, they'll work 3 months of a day shift and 3 months of a night shift. Many people take calls in the evening just to report into their morning shifts as if normal. Increased exposure to disease and violence. There's lots of reports of feeling a lack of managerial support, administration support, and the award system, so to speak, of like you're doing a lot of effort but not getting acknowledged, or your hard work doesn't get noticed. Staffing challenges, shortages. In fact, it is now a global health emergency, the shortage of healthcare workers. And then in addition, there's like a culture. So there's a little bit of a culture about putting others before self, even to a point of maybe your own self-care might be selfish. And then a strong historical stigma related to healthcare workers seeking mental health assistance. If I am going to work on my perhaps addiction tendencies, will I be seen as a less than provider by my colleagues in workplace? Just a little bit of data out there. 93% of healthcare workers report being stressed out and stretched too thin. I think a lot of us here feel that. 82% share being emotionally, physically exhausted. 62% think about leaving their job due to stress. And the top reasons of thinking about leaving the job is insufficient staffing, intensity of the workload, and just not really being able to take the emotional toll of the job. 61% of healthcare workers say they feel they're unable to give the care that they want to give. And 45% report that they're not feeling like they're getting emotional support that's needed. And if we take it to the American Nurses Association with nurse burnout, 1 in 3 nurses say inadequate staffing levels, 2 in 5 say their units are short-staffed. Over 50% say the workload is excessive. 96 out of 100 nurses report fatigue at the beginning of their shift. And half of nurses say that they just feel like they don't get enough time with their patients. And when we look at physicians, 88% say they're moderately to severely stressed. 54%, over half, say that they feel they're burnt out. And 59% of doctors wouldn't recommend a career in medicine to their children. I thought that was very interesting. So when we speak to this, what happens with the chronicity of stress? And I think, Laura, you mentioned it really great, that what happens suddenly over 3 years that you're taking on more workload and more work burden. And the chronicity of stress can turn into something that we call burnout. And burnout is a syndrome of 3 states. And one must have these 3 states to be in burnout, so to speak. When we talk about emotional and physical exhaustion, this is just being, really overextended emotionally and physically within the work environment or by one's work. When we talk about the depersonalization or cynicism, this is a little bit of like a hostile response towards one's work that they're doing and maybe even the recipients of their care. And what this turns out to is to not doing the job well, kind of just the bare minimum work, and maybe even the dehumanizing of patients, just kind of seeing patients as a disease instead of the human that they are and heart to heart. And with the diminished personal accomplishment or the inefficacy, this is not feeling like you can do your job well or not feeling competent or like you can achieve what you want to. And this can result in a negative sense of self. You know, maybe I'm not good at this. Maybe I made a mistake. Maybe I should leave this career. Interesting to note, the World Health Organization has an ICD-9, an International Classification of Diseases for burnout, and they define burnout not as a medical diagnosis or a problem of the individual, but they define it as an occupational phenomenon. And this is really important to note. One, it's great that we have, you know, an ICD classification because we can get statistical data, we have a definition, we can get financial data, but also it's really putting it into the organizations and this is an occupational thing. This is not because an individual can't handle the stressors of the job. Now, what are the consequences of burnout, right? We have it identified, we have it defined, and from the Office of the U.S. Surgeon General, they discuss these negative consequences that we have seen by research, and it impacts healthcare workers physically and psychosocially. So physically, burnout is linked to insomnias, heart disease, diabetes, substance use, anxieties, depressions, even interpersonal challenges, relationships. For patients, it impacts them. Burnout is associated with lower quality of care, increased of medication errors, and less time with the providers. Healthcare system, well, there's challenges with shortages and retentions. We have a decreased perception and patient satisfaction, and limited services there. And within the community, there's also an increased health disparity that's been documented and a worsening of population outcomes. It's also very expensive. So here is just a picture of burnout related to nursing turnover. So to lose one nurse and replace with another, for that just one individual costs anywhere from about $5,000 to like $55,000. Over time, hospitals have an average loss of about $5 million to about $7.5 million. Okay, so the other thing that's very interesting is this burnout thing's a cycle. So if you look here, we have this cycle around patient safety and quality of care, and in the bottom it says nursing shortage, but we really can take any shortage of an employee. So if we have a shortage and then it leads to inadequate staffing, to job dissatisfaction, to burnout, to turnover, to more shortage, and the cycle just keeps going around. All the while, we have a decrease perhaps of patient safety and the quality of care. So as you can see in this cartoon here, there's some healthcare workers and they're in the environment of patient care and they're looking at an explosion on the ground. And one of them says out loud, "Frank just up and exploded. I hope I never get that burnt out." And so really the question is how can we move from just hoping we don't get burnout to actively preventing? But also, if we are identifying burnout, what can we do for that? And, it used to really be on the individual to do this and have this and take on this burden. But, thank goodness there has been a shift and has been a change. And here we're going to shift from a me problem to a we problem. And what can we do all together? And in this beautiful picture, again, from the U.S. Surgeon General's office, you see at the bottom here in the roots, it's our healthcare organization, academic institutions, our communities, our licensing accrediting bodies, all of these people through the roots coming up through this tree of trust and moving into what can we do? How can we reduce administrative burdens and excess charting? How can we create a diverse, safe, inclusive environment? How can we create community partnerships? How can we make mental health accessible, for our providers? So I hope I've kind of just laid out a little bit of information. And the nice thing here is we have some wonderful panelists who are going to speak to how within their organizations they are actively combating burnout, trying to prevent that, and giving all these efforts to these important matters. Okay, so thank you. So with that, our first panelist will be Mr. Andy Ortiz.
Good evening, everyone. First of all, the elephant in the room. This picture was taken before COVID. So I had black hair then. I no longer have black hair, but I just thought I would say it so that all of you in the room, as you're looking at me, say, gosh, that guy has an old picture. This was a pre-COVID, and it's probably time for me to get a new headshot. Thank you, Barbara, for teeing up this important conversation. When I started, I went to HR school probably about 30 years ago when they teach, people that do what I do, how to do what we do. And there was a sense that what we did was important and impactful in organizations. And I've certainly always felt that way, but never more have I felt that today. And as I, think about the impact I can have on Cedars-Sinai, specifically in our workforce, I have so much energy, enthusiasm, and am really humbled because the challenges that Barbara just laid out are extremely big. And what I'm hoping to do in the short presentation here is to share with you some of the things that we're thinking about or how we're approaching this at Cedars-Sinai, and how it really impacts the larger healthcare for our larger community in Los Angeles. Okay. So I thought I'd start, here's the information about Cedars-Sinai, 915 beds. When I talk about Cedars-Sinai, I'm primarily talking about our flagship hospital in Beverly Hills, LA, as well as our physician network and our Marina Del Rey hospitals. That's kind of Cedars-Sinai. As some of you probably know, we also are part of a health system, so Cedars-Sinai Health System, which includes Huntington Hospital and Torrens, the Providence, Tarzana, Cedars-Sinai Hospital in Tarzana, and some others. But just wanted to make sure the data I'm sharing is primarily for our flagship hospital here. I thought I'd start with what I think is a startling statistic, and it certainly is consistent with the data that Barbara shared just a few minutes ago. Americans have shown, and this is data from Gallup, by the way. So Gallup is, the great organization that surveys Americans and beyond America, but they have a huge database about that where they collect data about about Americans in general, how they're feeling. And this most recent data from them, just about a year old, says 1 in 3 Americans have shown signs of clinical anxiety or depression, and the current state of suffering globally has risen significantly. And the reason why this is so startling for me is, for any of you that have ever felt a moment of panic or depression, you know that you don't think clearly. There's something that happens physiologically in your brain, right, where you're no longer thinking as clearly as when you're not in a panic state. And think about if we have a workforce, people that are coming to work, and this is the general American population. And Barbara highlighted very nicely that it's worse in healthcare. So think about if you have nurses, physicians, imaging techs, respiratory therapists that are showing up to work in a state of anxiety or panic. They're not thinking as clearly as they could be. They're not coming up with creative ideas about how, we talk a lot about care transformation. They can't do that thinking because physiologically they're not able to do it. And I love what Barbara said around this being a me problem, shifting it to a we problem, because we as individuals, and myself personally as someone who helps support caregivers, we have to find a way to get people out of that. And it really is a holistic approach that we're certainly trying to take at Cedars-Sinai. So again, I mentioned when I went to HR school 30 years ago, and I didn't, 30 years ago, I didn't know that there was such a thing as, HR school and that people do what I do for a living. And we used to always think about things as there was your work life and there was your personal life. And never would those two things cross, right? You always kept your personal life and who you were and your stress, your anxieties, your problems, who you were. That was completely separate from when you walked in the door. And when you walked in the door, your manager could only talk to you about the things that were related to your job, about your work. And so there were these very different buckets. There was a bucket for work and life that we could, share with you about. There was a bucket, and we didn't even call it then diversity, equity, and inclusion like we do today. But there was a separate bucket around that kind of work, a different bucket for wellness and well-being, and a separate bucket for engagement. And never did those things cross. Well, we've decided at Cedars-Sinai that those things do in fact cross, and as a matter of fact, some great data from Gallup tells us the more that those things are together, and the more that we involve the manager, the better our people will be. And so let's take a look at some of the information here. So the pandemic really put a spotlight on workforce well-being and the role that organizations and specifically managers play in determining the quality of life of employees and their families. And again, I go back to 30 years ago. Never did we think that as managers, we actually had a role in the well-being of a person and how they thrived in their life. And so again, we're starting to think differently, or I think we have to think differently about this moving forward. Employees' attitudes have shifted, placing more value on health and well-being. Some of this is, information that you all know. The line between personal and work life has disappeared, and the buckets that I talked about have merged together. Cedars-Sinai employees, and this is from our own survey that we do. We survey our employees twice a year, ask them about everything from wellness to their experiences at work, their engagement levels. And what our employees have told us is those employees who discuss their well-being with their supervisors show higher levels of engagement and decreased burnout. So just by the manager sitting down and saying, "How are you? Are you doing okay?" That makes a difference for people in their life. And it begins to change the role of the leader, which I'll talk about here in a second, and it really begins to help people out of these states of depression and anxiety. And COVID-19 accelerated the need to rethink our ideas of what work-life integration and well-being looks like and how we can support our physician and non-physician employees. So these are some of the things that we have done or implemented over time at Cedars-Sinai. One is we have broad-based employee assistance programs. So that means that we have a 7/24 access to counselors, resources for our employees, 7/24, 365. If you're a single mom and you're a nurse and you wake up and your child is sick, and what do you do when they're expecting you on in the unit in just an hour? You can call Bright Horizons, and they can send over if you're all registered and all that stuff in advance, they can send over someone to take care of your child while you can go to work, and it just gives you that peace of mind where you don't have to worry about calling in sick yourself or struggling to find, call a family member at the last minute to come help care for your child. So really putting in place and expanding what we're thinking about with EAP programs. And by the way, one of the innovations I think that we implemented during the pandemic was we made this available to physicians who are not employed by Cedars-Sinai. So, we have lots of physicians out there who provide service and care to our patients, but they're not employed by us. And we decided to push the boundaries. We had all the appropriate lawyers involved to make sure that we weren't, violating Stark laws and doing all the appropriate things. But we really made sure that we could make these services available to our physicians as well, those especially who weren't employed by us. Well-being and belonging organizational goals. So we started setting goals for the organization around this. Recruitment and development. So we increased the level of recruitment that we're doing to help not only with the staffing shortages, but to help those people in the units who are feeling overwhelmed. And we put a real focus on employee development so that people could find a pathway. Maybe they didn't want to stay in their current role, but could find a pathway to a different job that would enable them to continue to contribute and maybe even improve their economic situation by moving into a role that has a higher economic opportunity for them. We have a department that works for me called Work and Life Matters. It's a team of licensed clinicians who are employed by Cedars-Sinai, and their job strictly is to roam around and to round on the various units. And they check in with our employees to see how they're doing. That's all that their job is just to walk around and say, how are you? What can we do? And what we have found through some of that is we have found that, and this I shared this with the ladies who were on the panel here, just a couple weeks ago, we had one of our licensed clinical social workers on the team who was rounding, and they stopped an employee and said, how are you? How are you doing? And she broke down and started crying and found out that she was in a physically abusive relationship with someone, and she was very worried about her 2 children who were also living in that household. So as a result of that, the clinician reported it. We talked to that employee. We helped find housing and support services for her and for her 2 children. And she's in a, still a long road ahead of her in terms of trying to get out of that situation. But she now has a support network around her so that she can find a way out of that terrible situation. Specialized outreach programs, so our employee resource groups have become a very important part so that people feel like they belong. And workplace flexibility. So, for those people that can work remotely or in a hybrid model, we certainly provide that. The last slide I want to share here is how we're thinking about this, and this is really a question for all of us to ponder. Again, we used to keep the lines separate between work life and home life, and this is really, in my mind, a model for how we have to think about this in the future. The manager is at the center of this, and we have to train these managers of the future to be better listeners, more engaged, to ask more questions, to round more, to get out of their office, to not go to so many darn meetings, and to spend the time with their people. It's management by walking around and talking and listening to their people. And by the way, it looks really easy on a 2D 2D slide here in front of everyone. This is hard work, but this is the work I think that we have to think about when we talk about the workforce and the workplace now and for the future. So I am saddened by the data that we see about how many people are coming to work who are burned out, who are depressed, and who are anxious. But I'm hopeful that there's a pathway for us, and it's people like all of us in this room talking about this tonight. You could be at home, watching Netflix or, doing something like that. But I'm really glad that all of you are here to talk about this important topic, because every single one of us can have an impact on the people that are providing care to our patients. So I'm going to turn it over to my colleague, and we can continue the conversation. Jennifer, please.
My picture is also obviously pre-COVID. Got a theme going here. Thank you so much, Andy. And I really appreciated the sort of organization level perspective that you shared and saw a lot that resonates in terms of what we're also doing at Children's Hospital Los Angeles. I'm going to narrow in a little bit and focus on a particular component of our workforce, our nursing workforce, which obviously has been sort of in the center of the staffing challenges that we've been facing locally and nationally. And wanted to just start by sharing a couple of the things that as I round on the units and talk with our nurses, as I'm sitting in classroom with them or in the cafeteria, wherever we talk, these are the kind of things that come up. We're short 3 nurses tonight, and I can't keep up with all the care that my patients need. Parents are so angry about our visitation rules, and they're taking it out on me. The one that really taps at my heart is all of my friends at work have left. I don't recognize my unit anymore. I've been precepting every shift for 4 months straight. I'm tired of training all of these new staff. I get called every single day to see if I can pick up an extra shift, and I'm exhausted and I can't get a day off. And then the constant irritant, I can't believe the traveler working beside me makes double what I do. Why can't that money be in my salary? So want to share with you, we were really fortunate to receive funding from HRSA as part of some of the initial funding that came down from the Dr. Lorna Breen Healthcare Provider Protection Act last year. This is a federal recognition of the enormous stress that healthcare providers are facing and the wellness challenges that they have. And we feel really fortunate to be among the first group of grantees who received a $2 million grant for a 3-year project. The purpose of this from a federal standpoint is just to get some testing of initiatives going on to figure out what in the world can we do in this space and how do we measure impact. So we've been trying it. At a time when the word resiliency has become a little bit of a bad word, we've had to pivot and think about how to brand what we're doing, because we are leveraging the community resiliency model that the Trauma Resource Institute has that really focuses on bio-based skills to help in the moment with that stressor, recognizing that we can't in the course of a shift unpack all that's happening. But what we can do is center ourselves, bring ourselves back together, help each other do that, and then figure out how to address the ongoing and bigger concerns at a more appropriate time and place. We're building community around this, and you can see this represented here in our green revitalized shirts. We had a really fun time on St. Patrick's Day with getting everybody in their green shirts, and it just speaks to the sense of community, which for me comes back to that quote on the slide around, I don't recognize anyone in my unit anymore. Our focus has been on rebuilding our community that's been so damaged by the turnover during the pandemic. And just a really quick note from one of our nurses said, I didn't go into the session with an open mind, sort of thinking this resiliency crap, but the session did change me and made a difference in my life, and we're seeing that in so many ways. What I really want to focus on, though, is our professional development, wellness, and retention strategies. And at first glance, I think professional development and wellness maybe don't always go hand in hand, but I would argue that they absolutely do. I think by investing in our professional development for our nurses, we're saying to them that we know you're whole and proud professionals, that we understand that you have a why as to why you came into this profession, and we're here to help you remember that and grow that. And we're not asking you to do more work, we're asking you to do different work that helps you really understand why you're here and what you're doing for your patients and families. So I'm going to walk through some of these. Of course, the biggest thing we can do is get more nurses in the building to help us staff our units and to take good care of our patients and families. So we have ramped up and are really going heavy on trying to bring in our new graduate nurses who are our most consistent pipeline. And so doing a lot of recruitment efforts and trying to get out there. You can see a little snapshot from my LinkedIn. Follow me if you'd like to on LinkedIn to hear about our new grad residency program. But what's really fun is that we figured out ways to get our nurses involved in this. So we established an RN-driven hiring committee, and so they're helping us interview these new graduate nurses. We've also established what we call the Transition to Practice Committee. So we're getting those experienced nurses involved in designing and iterating on our residency program so that they feel invested in caring for their new colleagues and making them want to stay with us.
We also had to do a big overhaul of our residency curriculum. We had a very traditional classroom-based curriculum that just wasn't meeting the needs of our learners well before the pandemic, but certainly in the pandemic when they really came to us with deficiencies in the skills we would expect them to have because of a lack of clinical placements during the pandemic and just the recovery phase we're in. So we shifted to an experiential learning model, trying to make it as fun as possible for them to learn, to acquire some of the basic skills. We've also extended the support that we're giving the new grads so that really it's a year-long program of touch points with us and learning as they progress developmentally. And here again, really fun opportunity to involve our experienced nurses in helping us teach and serving as facilitators in our sim labs and getting just the whole community involved in bringing on our newest team members. We also have recognized that that our new grads are really vulnerable. Despite all of the support we can give them in our residency in their first year of practice, they have a lot of learning and growth and career development to do. And actually, really sadly, we began to see, certainly coming out of some of the initial cohorts in the pandemic, we were losing up to 50% of our cohort, even at that 18-month to 2-year mark, because guess what? The travel agencies began accepting nurses with less experience. And so we realized we needed to step into this space and offer more support to be with them, to offer advice and friendship, as well as paint the picture for them of the amazing career that they could have at CHLA if they hang in there with us, and setting career goals with them. So this is a brand new program that we've launched. We are getting phenomenal feedback. We have one-to-one mentorship throughout the second year of practice. We have experienced nurses stepping in to serve as their mentor and, again, remembering their why and engaging in a really fun and different way. We've also leaned into professional certification and getting energy around a campaign to help people study for their certification exams and then be successful in passing them. So we've made study materials, review courses for no cost to the nurse. We've paid for their time to study, and we've made a whole fun campaign. This picture on the left is from Certified Nurses Day, which was just on March 19th. We went around and celebrated and had a party, and we have a goal that we've set for the end of this fiscal year in June to try to get as many people through their certification exam as possible. And then this is one of our study circles that we're doing virtually. So just lots of fun energy around certification, which we know has direct links to the quality of patient care, and again, connecting them back to their why. We also know that we have really experienced nurses who are going on and pursuing higher education, and then we haven't had great programming to support them when they come out as new grads, newly prepared doctoral nurses. And so we're actually launching our first cohort of a postdoctoral fellowship program. We just selected our first two fellows. One is a DNP-prepared individual and the other a PhD, and we're going to be walking through them with 2 years of salary support so that they can step away from their full-time clinical responsibilities. Half-time they'll be with us doing projects and research and growing their portfolio of scholarly work, which again, investing in them and their why and helping us to push new knowledge in the field. We've also invested in our professional ladder. This is the mechanism by which nurses can gain promotion when they demonstrate their expertise in their clinical skills and their whole professional self. And so we redesigned the application process to make it more streamlined. We've created a mentorship program here, and we launched some formal recognition ceremonies. We have this really interesting, beautiful library in the basement of the hospital that literally no one knows about. And we were like, hey, let's open it up and have a tea party. And so our chief nursing officer is there celebrating all of our newly promoted nurses, and just the good energy in this room and the stories about the why. I'm nearly in tears every time I attend one of these. And then finally, last bit I have here, we've also wanted to get people back out traveling and engaging with their networks and their colleagues and learning. And so we've opened up a lot of funding to support folks either just traveling to learn or because they have a poster or a podium presentation. And the amount of just good energy and fabulous ideas about what else we can be doing that are coming back from these conferences is really energizing for us. And so with that, I am going to hand it over to, oh, I think we have a little bit of an error there. Hannah.
I mean, Andy's a pretty impressive guy. I'll take the name, I suppose. Hi, everybody. My name is Hannah Reichel. I am a grateful alumna of the MPH program in the Department of Health Policy and Management here at the Fielding School at UCLA. And I also am really grateful to get to teach in them in a couple of our executive programs. And but this opportunity to come and be in community feels particularly special. And I think I bring a slightly different perspective and sort of conversation starter to this bigger conversation, bringing a solution or another part of kind of opportunity for employers to support their employees. I think building off of what Barbara and Andy both said about making the me the we, and realizing that these buckets of life outside of work and life at work are no longer separate, I want to invite us to think about something very exciting in some of our lives, which is babies. So this is a little different than scary stats about sort of how the world and demise of the last few years has been an added stress. But I want to invite everyone in the room and on Zoom to close your eyes for a second and to think about the babies in your life and the parents who are raising those babies. And I want you to think about how wonderful pregnancy can be and how difficult it can be for some on a fertility journey to create their family, what that looks like for folks who are pursuing surrogacy or adoption or fostering or have long fertility journeys, or for those of us who may fall pregnant and decide that being pregnant at this moment in time is not the right choice for you and accessing appropriate resources. And then, let's say the babies do come into your family, or there's new littles in this world, that now there hopefully is a village around this baby, but a lot of us don't have the family support around us right in town, right? That these babies and parents might feel some stress. And those parents, unfortunately, in the United States, don't have the luxury of significant time or well-resourced support right at that moment when a little is coming into their life. But those babies, they smell so good, they sleep, they cry, they eat, they poop, and they're so full of joy and hope and optimism. And oftentimes in a family, a baby can be this like incredible beginning of a new chapter, right? And so as you think about these babies in your life, now I want to sort of help you transition to think a little bit about what supports do the people who are caring for those babies need. And in your life, whether you're a parent or whether you have any reflection of being a baby, or you work with people who are parents, to just think about the different ways that stress emerges in our lives. Who's going to take care of this baby while I can go to work? How am I going to breastfeed if I want to be able to breastfeed my baby and have a job? How am I going to pay for things like an IVF journey? How am I going to understand what to do in the middle of the night when my baby won't latch or fall asleep? And Maven, which is the company I work for as the Director of Clinical Quality, is the largest virtual clinic to support people who are trying to form their families with dignity and tangible support, to enable folks to have strong, healthy pregnancies, healthy birthers, and healthy babies, and to enable parents to have the levels of tangible supports they need to thrive both in this sacred new chapter of their lives and to enable employers to support parents in returning to the workforce. We know disproportionately that women who have a child are faced with choices in the United States, especially, and globally, about whether they return to work or they stay parenting. And the cost of things like childcare and additional sort of things that happen in the life environment really impact that. So I want to talk a little bit about sort of what is a solution to that. And Maven is an end-to-end, all-in-one platform from preconception through after menopause, to support families that are in their forming stages, to provide support both in terms of coaching and education, but also point in time ad hoc, like middle of the night lactation coach or middle of the night OB-GYN appointment. I'm not quite sure. My heartburn seems like it's gotten a lot worse. I'm not sure if I should go in or not. Before you sit in that waiting room, you can have a sort of a trusted, licensed, credentialed OB-GYN you could check in with. And so Maven, over the last 8 years, we just celebrated Maven Day last Friday, the Maven birthday, is sort of providing services across these 4 buckets. Helping people form their families, whatever that looks like, whatever your partnership or your village looks like, adoption, surrogacy, fertility support, natural conception, general wellness, partner support, things like these. Supporting folks while they're pregnant, while their babies are young, both physical and mental health support. And then there's sort of there should be like a ... because hopefully like having a baby and menopause are not the same moment. But in the last year, Maven has launched a new offering supporting employers who want to support employees who are going through menopause, because we know that sort of physical changes that happen don't only happen at one particular moment in your life, right? And so these sort of 3 areas, providing clinical support 24/7, 365 in 175 countries, is one of our key offerings. We also have a product that's called Maven Wallet that allows employers to, it's a third-party kind of financial product to support employers reimbursing employees for services that they receive, like IVF or IUI or sort of fertility journey benefits. We also, this product was launched right after the sort of decision around Roe, which I feel like I can't even say that out loud still. I thought that would get easier. But as the decisions about access in certain parts of the country became more stressed, Maven really wanted to respond in the market and say, hey, we will help employers reimburse employees for supports that they may need accessing reproductive health care without the employees needing to identify themselves, which I think is just a really like, what does the world need? This is a tangible way to meet that need. And then providing emotional support. A lot of things around getting pregnant, going through pregnancy, becoming a parent, or adding another little to your family, have an element that may not require an OB or a pediatric or a mental health formal clinician visit, but you may want to have sort of extra support. And so we have a team of care advocates and support representatives who support folks 24/7. It's an app-based messaging, but also has phone and video capabilities as well. And I think this is sort of one of the solutions. I don't think this is the solution, but I think I hope is a demonstrative example of sort of how there is a need for this complementary care in this time where our traditional health systems are doing the best that they can, and our payment structures in the United States may have some gaps. So this is sort of to walk us through briefly, what would a pregnancy journey look like? At Maven, we have about 90% of our members complete a health assessment. 77% of our members enroll in Maven during their first or second trimester. So a lot of folks will join Maven at a time where they're learning about their pregnancy. They're started at the beginning of their journey. They're working with an in-person care provider or system, but they may want a second opinion, or they may want to talk to somebody about, like, I don't know. I had a member story from the other day of somebody who said, I really think I should be seeing my doctor more often, and needed to be reaffirmed that actually in the beginning of pregnancy it's okay to have some time between those appointments. We're really trying to systemically identify how virtual care can be useful, and really what are the critical moments where a virtual touch could support positive birth outcomes and leading indicators. One of those we know is that when folks have a birthing plan, life does not always go to the birthing plan, but by having a birthing plan, you are 27%, we can lower the C-section rate by 27%. We know that from the evidence in the industry. We also know that just sort of like support matters and well-being matters, and that those who sort of met with sick providers feel that their sort of health and mental health is better managed. So this is sort of an example of that journey. I want to share a little bit about kind of who uses what kinds of services. And I know these bars are pretty small, but from left to right, we're looking at fertility, third trimester, postpartum, parenting and pediatrics, and menopause. And the sort of big colors, or the salmon color and the red and the periwinkle, are things like lactation coach, OB, doulas, nutritionists, physical therapists. You can see in the menopause area, there's a kind of green bar towards the top, and that's for career coaches. At Maven, we have more than 30 different kinds of providers, and we use that term to both be inclusive of traditional licensed clinicians like OBs and pediatricians and mental health providers, but we also use that to describe things like doulas and career coaches and sex coaches and fertility coaches. And I think a lot of these kinds of roles, one might be able to find in the market if you lived in a geography where something like that existed, but you'd often, the cost of sort of paying out of pocket for those things can be really exclusive. And one of the goals that Maven has is to sort of build the model that will work around this complementary care system and scale it to everybody who would benefit from it. And so we also want to do that in ways that are not exclusively for tech workers, right? More than half of Maven's clients are companies and nonprofits who have less than 1,000 employees. And we really have kind of in our taproot, to use that tree metaphor around me as we now, we also really want to be thinking about, like, as our core values, how do we meet people where they are, with folks who represent what they look like, languages they speak, the kinds of ways that they want to engage in a health system, which are also changing. As millennials are becoming parents more and more, and Gen Z are becoming parents, they're looking for their healthcare systems to provide them support in different ways than previous generations, as are populations that are facing different socioeconomic challenges. And so I think that, like, our organization and my boss, our chief medical officer, Dr. Neil Shaw, really likes to talk about how our approach to health equity is grounded in science. We collect race data on 2/3 of our members, and we use that data to understand utilization and outcomes by race. And we know that when folks who are non-white have access to this expanded set of different kinds of providers, that their outcomes are less likely to demonstrate the national disparities that we see in other data. Does that make sense? And I think personally, this is an exciting week. I don't know how many of us are celebrating Black Maternal Health Week, but you are now, if you didn't know you were before I started talking. But we also, I think, are very proud at Maven to really be trying to walk the talk as we really try to invest in making sure that our provider workforce is reflective of the populations we're serving. So nationally, 4% of mental health clinicians in the United States identify as Black. And on our care team, we have 35% of our mental health clinicians identify as Black. And that is not to say that there is a magic amount, or that we will ever meet the need of everybody, or that we don't want to make assumptions that folks always want a clinician who reflects their race. But we're really trying to be intentional and data driven around how we understand how to meet the unique needs of every family and every person on their family building journey. And I think just to I have one more slide that sort of shows the stats of Maven and its growth journey, but before I go there, I want to just mention that I'm like born and raised in the public health world. I'm the daughter of a community health evaluator, and I feel like I grew up in this community here in Los Angeles professionally over the last 10, 15 years. And I really see that, like, the future of public health needs partnerships and needs players like tech, and that this is an interesting example that's really leading with the evidence-based practices. This isn't just to be, Maven doesn't exist to, like, we don't exist just to have a product that does well and goes public. And I think that this is an example of where tech can be doing really, really good work in the world. And that employers see, and we have demonstrated ROI relationships with more than, this is where I am the quality person and not the salesperson, that we have relationships with more than 450 employers globally. We recently expanded to serve 365 days a year, 24 hours a day in every zip code globally, which is a pretty incredible growth journey for an organization that started with one woman at a table with 3 employees saying, hey, there's all this health tech action happening, who's taking care and supporting women and their health? And so I'm really proud to have joined this team a little over 7 months ago, and really excited to see sort of how we can leverage the resources and the technology and the data that organizations like Maven have to really meet the needs of the nurse who's trying to decide whether or not she's going to go back to work because she really is committed to a breastfeeding journey, or the parents who are trying to decide whether the cost of childcare are really worth 2 parents working. Or the people who are just sleep deprived. I talked to 3 people before the panel started tonight, 2 of whom told me that they haven't slept in days because they have newborns. And I think in the room where we are right now, this is sort of a universal experience that parenting, for a lot of people at any point in your career, whether you're a young parent or you choose to sort of focus on your career and become a parent later in life, that this is a really vulnerable moment in your life. And employers who are already dealing with sort of the stresses that my colleagues here have outlined, that taking care of parents feels like one tangible way that our sort of systems need to evolve universally. And I think this is a piece of that. So thanks for hearing me out, and I'm excited to hear everyone's questions.
So panelists, your Microphones have a very secret button at the bottom that slides.
Okay.
Oh, if you see a red dot on the side, then you can click below that, and that should turn. I'm going to try and mute this visual so that you guys aren't blinded, and we'll move into Q&A.
Great. I think I will start out with a couple questions and then we will open it up to all of you and we welcome all questions. Thank you for being here. Let's see, let's start with Jenny. I was wondering if you could talk about, and thank you for presenting on the excellent program, if you could maybe discuss or mention, when implementing this program, some possible measurable outcomes or things down the line to kind of see how it's going.
Yeah, absolutely. Thank you. So I think kind of two buckets of things that we're looking at. One is, as Andy mentioned, we were doing them quarterly. We've backed off a little to do biannual employee engagement surveys, and we know from trended data that our wellness scores are, as a whole hospital, are right about the healthcare benchmark, but our nursing wellness scores are below benchmark, and so we're tracking that very closely. There's also a question that to me is really important, again, coming back to that sense of I don't know anyone in my unit, and it's a metric around belonging. And so for me, that's a really important one that we have our eyes on, and that we're hoping that some of these programs are helping to drive that. And then, of course, and this sounds a little bit callous and more of a financial thing, but I really think it's a demonstration of belonging and sense of community is our turnover rate, right? So we're tracking that very closely and have begun to see some stabilization in that turnover, and that's exciting and not cause for celebration yet, but we're tracking that very closely.
Thank you. Let's see, Andy, question for you. Could you speak to all the employees in the organization? I mean, there's a lot of focus on healthcare clinicians and providers, but we all know that it takes a village and many other type of employees to make a system run. And how also does one reach them or speak to them or get them engaged and involved?
Right, great question. Thank you. So when we look at our data, because we, similar to what happens at CHLA, we do pulse our employees twice a year to find out about their attitudes and feelings about the workplace. We ask questions about belonging. We certainly look at turnover data, those type of things. But interestingly, we have found that the issues are similar whether you're a clinician or non-clinician. So the folks in accounting, the folks who are doing billing and coding, that all of the issues really are the same. Now, what we are finding is whether someone is on site versus off site, that there are differences in that. We tend to see that our employees who are working remotely 100% of the time, that their levels of satisfaction is high, but interestingly, we find that they feel less connected to the mission. Well, that makes a lot of sense because you're not there, you're not on campus, you're not seeing, participating with your colleagues the same. So we do have a thoughtful approach to looking at the data and deciding, how do we touch people in a way that's going to resonate for them? And so our fully remote employees, we have a certain strategy for trying to engage and touch and talk with them, different from our caregivers who are on site providing, care every single day to our patients. So we try to be very thoughtful and intentional about how we do that. I think that over time, kind of what I get from all this is we're all human beings, whether we're clinicians or not clinicians, and we have the same kind of needs and motivations and the same stressors. So I think that, I'm saying something obviously, that everyone gets. The pandemic was tough for everybody. And so now that we're coming through that, what are some new models and ways of working that will be different and support people in a way that's going to be real and work for them. And so that, I think, is the important part. As leaders of organizations, we have to always just be tuned in and not try to treat people as just clinicians or non-clinicians, but think about how do we have to tailor the work that we're doing based upon who groups of people are, and try to do something that's going to resonate for them. And just thinking about that, last thing I'll say is just even generationally. So we know that generationally, most of our young employees love being at home. They love being able to work from home and try to do work there. Where our employees who are older generationally, they really get energized by coming into work and seeing their colleagues. It's how they've grown up. That's how they're used to work. So there isn't a one size fits all. It really takes kind of a multi-pronged approach to tapping our employees.
Thank you. Thank you. And last question for Hannah. Could you speak to how Maven can reach people across the lifespan and at many different life stages? I think you did a great job focusing on, the reproductive aspects, but as far as other lifespans, yeah.
Yeah. I mean, I think about what folks who are out in the workforce, whether they're the accountant or they're on the front lines delivering care, or they're making life happen in a remote job. Those are people who are partners of folks who might be starting a family, or they're folks who are trying to get in the best shape of their life and are not at all interested in having a baby yet, but they want to be have support around understanding nutrition and understanding what it would be like before you want to have a baby, what kind of health and wellness and mental health goals you might want to have. There is I think, along the life course of a reproductive journey for women and birthers and partners of folks who are supporting family building. There are many different phases of that. We've seen a huge uptick, I think, in the last few years of folks who are deciding to freeze their eggs. That's something that Maven has a track that supports. Or people who want to learn about what are the different ways that I could have my family journey look like. I talked with one of our care advocates actually this morning, who was helping a member who's on an adoption journey, a single parent by choice, who wanted to understand what would it take to adopt a baby or or work through the foster system in the state of Ohio. And they were nervous to call the state agency. They felt like if they went to that first intro meeting, they might feel on the hook. They just really wanted to learn more. And I think that these are the kinds of things people sitting in cubicles are thinking about at 2:00 in the afternoon when they're trying to decide, I did my first round of data analysis. I need to do 3 more pivot tables, but I'm stressed out thinking about what do I want to do this or not right now? And maybe that's a very specific example, but I think that there are folks who are really dealing with the stress of parenting not young kids, or trying to think about what's my financial planning journey like the next few years, depending on when my kids go off to college, or what is going to happen with my body or with my partner's body when they go through menopause. And I think for me, having worked for years in brick and mortar health systems and seen how employee wellness and support systems have grown in the last 10, 15 years significantly in terms of people really creating tangible supports, I think Maven is one piece of that. And we've seen, as small organizations, large organizations have started to partner with Maven, that the offerings the needs continue to arise. And I've been impressed with Maven's ability to really leverage a tech-enabled platform to evolve with those needs. And I think that we all need different things at different moments of our lives, and we might not want to tell our boss about them. We might want to. So I think there's a place for organizations like Maven that provide employees another outlet. I think another example, if you think about how health plans have connected more directly with these direct-to-consumer mental health supports, where you can sometimes go to your health insurance website and get direct access to one of these, talk to a mental health clinician fast. Maven is filling a very similar space. Yeah.
Thank you very much. Okay, so I think we'll now open up to anyone in this room if there are any questions or thoughts or comments. Okay. right here. Gary.
It's for Andy. So you talked about how the manager is the hub between, integrating all the different elements to work with employees. What sort of programs is Cedars putting in place to enable the training? Because that can be a big shift for someone who's more of an operational frontline leader than to move into that.
Yeah, so thank you for the question. So about a year ago, we started asking, we put a question on our pulse survey, and I'm going to get it, won't get it 100% right, but it's a version of, has your manager asked you how you're doing? It's a version of, how engaging is your manager being around just checking in with your own wellness. And it started a firestorm because managers, I had people calling me, emailing me, IMing me, texting me saying, that's not my job. Like, my job is to run this operation. I got to get those ORs turned around and ready to go for the next patients. And my job really isn't to sit and ask my employee how they're doing, what's happening with them. And so the more that we began sharing data, so we decided, let's find out what the answers were. How are people going to respond? And again, we did some analysis and found out that those employees who said, yes, my boss asks me how I'm doing, their level of engagement was significantly higher than those who didn't. And so we started with the data and said, I don't care if you think that this isn't relevant, it's showing up here in a way that it actually is relevant to these folks. And I think we also had many people who, came from the school of someone's personal life is separate from their work life, and that who am I to be asking and imposing, myself on them. And what we try to do with our managers is explain to them, we're not actually asking them to solve the problem. We're not asking them to be a clinician or a social worker. They are not trained in that way. And it would be terrible if they sat down and tried to do a therapy session with their employee. But instead, by asking the question, hearing what the employee is saying, and then determining what can we do about that? What are the resources that we have who can help? We know that we've got people whose full-time job is to round the hospital and check in, and these are licensed, clinicians. Like, let me check with them. So we've done a lot of education and training of our managers on that front, and we've done something that we call coaching circles, where we invite managers to a virtual session where they log in via Zoom or Teams, something like that, and we bring up these issues. And so we ask them, how many of you ask your employees, how they're doing? And then they have an opportunity to talk about it virtually as a group, to break up or break out into different sessions, and to really practice being able to ask that question so it feels and is authentic, and ultimately helping the managers understand that they are an important hub in this moving forward. Like it or not, it's just the reality of how the workforce is evolving and the needs that our employees have. So we try to do lots of education like that, mostly informal, so not like a formal training class, but mostly informal ways and education to help them understand. Thank you for the question.
First of all, I want to say thank you so much, all of you guys, for your time. And also, I just want to highlight, even though you said your pictures are before pandemic, I just want to say, in my opinion, you guys look like in 30s. Thank you. Sure. That being said, I was wondering, you all touch on different aspects of burnout. I was wondering, what is the approach that you guys are taking with regard to equity? Like, for example, I'm in 20s, I don't want to have a kid. I was wondering what kind of challenges you guys faced and how you, like your organization, is approaching those challenges with regard to equity.
I think this is an amazing question. I think we identify risk factors in our patients and clients all the time. It's a little bit more challenging to identify our own risk factors. And the data does show, I was looking at all these nursing students here, I was like, yes, I'm so glad you're here. Because the data does show that risk for burnout is highest in nurses or in healthcare workers that have started within the first 5 years. And very interestingly, the data shows that it is people who are not in partnerships or do not have families. And within nursing, men are more at higher risk. In physicians, it's women. So I think it's so important to know our own risk factors, right? If I'm at risk for cardiovascular disease, am I at risk for burnout? These kind of things. So I do find that the culture has shifted because honestly, I feel like when I started in this profession in the 90s, to show any weakness was too vulnerable. And when I had my own experience of burnout actually in 2008, and I actually had to take a pause from my career, and it was profoundly paralyzing for me because I loved my profession so much. But at that time, when I was asking for help from my colleagues, no one had any answers. And at that time, when I started to look at all my role models and mentors, no one had a work-life balance. And it was very panic-striking for me because is this going to be my life, So I think you bring a great question in that identifying our own risk factors, but also with the organizations we're going to be employed, what do they have set up for us to succeed, And I always tell people when you're interviewing for the job, you're also interviewing them, and to really touch on that. And so, yes, there's that aspect, but there's also the aspect of us too and what we're doing for coping. And I find a lot of people think, well, once this happens, it will get better, or once I graduate, or once I get board certified, or once I get my first job, or once I do this. And, it kind of just never gets better, So it's very important to find our own resources to take care of ourselves and our self-care, and that's not selfish. That's actually a completely sustainable plan, and there's many ways to do that. But also to normalize this within our organizations and within this community. And I think this is one, hope for this panel. But also, I personally, being in the industry for 20 years, I have seen an incredible shift. I mean, when I started, burnout kind of wasn't discussed or talked about. The fact that it's just so ubiquitous and being thrown out there is a really good start. So I think that was my first thought is what a great question and what a great way to identify this. And then, when you are purposeful into whatever path you go, part of that question too is how am I carving out self-care or well-being, or what does this workplace well-being look like, and to be very proactive in that. So those are just my first thoughts. Thank you. I don't know if anyone else has anything to add.
Yeah, I'll jump in on the equity piece. So I had a moment, let's see, today's Wednesday, Monday of this week, where a vice president, male, came up to me and said, I'm suffering. I have, and right now, he's suffering with symptoms from long COVID, right? So he was one of the early folks that caught COVID, and he's really struggling and suffering. And the fact that he came and was able to say that, and that afternoon, we said, take a step back. We value you, we love you, we want you to be here. You're a great contributor. Let's put you on a leave. Let's do what we need to do in order to take care of yourself. And he sent me a text last night and said, thank you so much. All the paperwork is processed, and I start my leave tomorrow, meaning today. So, that's a sign, when I think about equity, again, to the point that Barbara made, it used to be a work environment or a work world where you never showed weakness. You always kept pressing on. You always pushed through it. And I know that made such a difference for him. And he will be committed to Cedars-Sinai forever, because when he went and talked to his boss said, you got to take care of yourself. Like there's no other option. You know, we need to make sure that you're okay. That's the first priority. The work stuff will take care, you know, you've got a team of people, we'll figure out how to solve for the work issues. So for me, that's a sign that that's like equity in action, because someone wasn't afraid to raise their hand and to be vulnerable and say that they had a need. And I'm grateful that we as an organization were able to respond in that way. And I don't know how we would have responded 5 years ago, 8 years ago. Might someone have raised their eyebrow and said, oh, this person's going on a leave, and what does that mean? And, and that's not at all like how it happened this week for him. So.
Hi. I'm struck by the statistic that almost 60% of physicians tell their kids they shouldn't go into medicine. And so I'm wondering how your organizations are thinking about future pipelines, whether it's of physicians or nurses or anyone who's interested in being a healthcare professional. How are you thinking about the future, attracting people to the industry, recruiting them and retaining them, or making sure that they don't retire early?
I will say, I think this is a space in which we have so much opportunity, and I keep dreaming about all these different programs that we could do, and I just need some funding to do some of them. So if anyone wants to donate we have brilliant ideas. But we do have a program that's been longstanding, and I think we've recognized an opportunity to even increase it. It's called Camp CHLA. We bring in high school students and give them an exposure to all of the roles, clinical primarily roles that we have within the hospital. And they spend a week with us during the summer, and we do some teaching with them and some skills lab, and then a ton of shadowing, and they just have the best time. And it's been we've had some really successful, some success stories out of it. We have one gentleman who's just finishing nursing school this summer, and I'm very confident he'll be joining us as a nurse. But he, as he was applying to nursing school, was working with us within my department, and he attributes all of that to his experience in camp. I think we have a lot of opportunity to do a lot more of that type of work. Particularly in some communities that we're really committed to making a connection with and digging in deeper to support. And so I think, again, ton of opportunity. Also, we're trying to really sort of diversify our recruitment efforts, be out there talking with students much earlier about the amazing careers that can exist at CHLA and within healthcare more broadly. And then we are trying to do, hopefully you saw a little bit of a reflection in some of what I talked about different stages of career and trying to have programming for folks, but also just being really thoughtful about, even for our most senior staff, we have a wisdom worker program. So if they're not quite ready to say goodbye to CHLA, but need a step back from the grind of full clinical work, then we have opportunities and so many needs for them to help with teaching BLS and PALS, or serving in our family resource center, you name it. We've used these wisdom workers everywhere. They were key to our vaccination efforts. And so keeping that engagement and that wisdom that they have for as long as they're willing to share it with us.
I'd also add, and I'm maybe an unusual person to answer this question given this panel, but at Maven, we have 1,000+ providers who work, who see patients, and some of them are folks who work at Johns Hopkins, or work at UCLA Health, or work at the University of Michigan, or work at Kaiser Permanente during the week, and they want to dedicate 5 to 10 hours a month to do virtual care, or they want to explore the idea of doing virtual care and reducing their in-person practice while they have young kids at home, or something like that. And I see from kind of what I have learned from working with these providers very closely is that like creating new ways for clinical work to happen, or a diversity of tasks that, I talked to a clinician this morning who told me, I feel like I love my my at the hospital work more because I get to sort of have the personal connections with members on Maven for a set period of time each month. And I see as maybe the resident geriatric millennial on this panel, I think that millennials are also looking for more. They're not sort of people want to do different things every couple years, or what the journey looks like. And so I think figuring out how we as systems and education, both in education institutions and in big health systems, how we sort of support those journeys. And Jenny outlined a lot of the ways that we could do that for nurses and other kinds of clinicians. And I don't think that tech is going to take over by any means, but I think that creating opportunities for people to think critically and to do the human side of healthcare, that I hear from friends and colleagues is sort of one of the biggest drivers of burnout, that creating those opportunities, I think, is one of the tangible strategies to work on that.
I'll add just one or two things. I love wisdom workers. I'm going to steal that. That's awesome. I love that. So at Cedars-Sinai, back in 1994, after the riots in Los Angeles, we started a program called the YED program. And it's where we take students, high school students, high school juniors and seniors, primarily from Fairfax High School. And most of them are underserved and people of color. And we have provided them with jobs on campus at Cedars-Sinai where they can shadow and learn the whole gamut of what it's like to work in healthcare. And it's so great when you see them in scrubs and, you know, working in the ORs and trying to understand the work that we do. And so not only is it a job for them, so they're able to leave, their last couple periods of school, their 6th or 7th period, whatever it is, they're able to come directly to campus. We have, a bus that picks them up, brings them to campus. Excuse me. They do their work and they're paid for it. So they actually get paid, so it's like a job. It's a work-study kind of program for them. And we have many of those students who remain a YED student once they graduate high school and start their college career. And we just had a meeting of this group of people. We have a few doctors, so only 2. So, to Jennifer's good question, I don't know the answer about the doctors, but we certainly have lots of students who have come through that program and are now, there's this lovely lady I was talking to the other day. She's she has her BSN, she works in our emergency department, and she was a YED student. And so we have them sprinkled all throughout Cedars-Sinai, and they all attribute, their success by starting in high school and having a job where they were paid and they were able to, come to campus every day and learn a little bit more about what we do. So, and I know we have other programs where we reach out in the community, but the last thing I'll say is we have our allied health school. We just received funding, $30 million worth of funding from Chuck Lorre. So the gentleman who does the Big Bang Theory and lots of other TV shows on television. He is a big proponent of how do we find educational opportunities that don't necessarily require a full college degree, right? So were awarded $30 million by Mr. Lorre most recently. We're very grateful to him. And we're going to start a respiratory therapy program, a pharmacy tech program, a clinical lab scientist program. So there's 6 different programs that we're starting with. And we really think that those students will help us with future workforce, certainly not doctors, maybe not nurses, but vital healthcare workers, the allied health profession that we need to support. And then maybe from there, I don't want to put words in Mr. Lorre's mouth, but he has said, let's see how this goes. And maybe there's a way we can, expand this beyond that if we have great success. So anyway, I think those are some of the programs that we do to help think about our future workforce.
Thank you all so much for coming. Thank you to our panelists who I think really brought a variety of ideas and hopefully gave you some ideas of things that you can do in your organizations, that you can do in your own life to help yourself, to help others, to really think, back to the point about it's not just about me, it's about we, and we're sort of in this together. I just want to close by saying that Paul Torrens, for whom this forum is named, really strongly believed in the role of discussion, the role of sort of bringing the community, our stakeholders, our university students, sort of together to have these conversations. If you can, make a donation so that we can continue to keep this program free. And before we conclude, this is the final health forum of the academic year. There is one more opportunity if you want to engage with some public health folks and come to our Leaders of Today, Leaders of Tomorrow celebration on May 4th. The leader of today is Eric Wexler from Providence. The Ira Alpert Service Award will be going to Jean Belgroski. And again, as I said earlier, there will be a tribute to the late Paul Torrens. So thank you so much for joining us, those of you who are here in person and those of you who are watching on the live stream. And please enjoy the rest of your evening.